Welcome to the session, which is a 1-hour session sponsored by Mera Life. And we are going to now be looking at the next generation technology and its key features, and looking at the procedural and clinical benefits that this offers. And we want to understand the importance of precise commissural and coronary alignment for the lifetime management of TAVI patients, and to understand what the role of intermediate and extra large sizing is in addressing unmet clinical needs. And I'm very pleased to be I'm the anchor person. My name is Farrell Hellig from South Africa, and I'm pleased to be joined with my spokesperson, Andreas Baumbach. And we have our discussants from my left, from your right. We have Christian Turkison, Francesco Bedogni, Marcin Protasiewicz, and Michael Hilke. And I will hand over to Andreas to explain his role as spokesperson.
Before we go to the first speaker, just let me remind you that you can come up at the end of the talks, come up to the microphones, ask a question, or ask a question with the app, and I will see that here and will hand over the question to the chairperson, of course, and hopefully we can answer it. And at the end of the session, a reminder, you can actually rate this session in the app as well. So if we're really lousy, you give us 1 star, and if you really like it, you give us 5 stars.
Okay, we'll try our best for 5 stars. So let's move to the first talk, which is by Ignacio Amat Santos, responding to unmet clinical needs, design considerations for next generation TAVI device.
So it's my pleasure to do this presentation. These are my disclosures, and I will focus, I was thinking, what do I want from the next generation devices? So although I'm going through the properties of octa-core, this is applicable to any new device. We want low profile devices that are able to navigate across the anatomy very easily without causing any damage, able to cross properly the valves, with an easy positioning and a stable positioning, with low rate of the life-threatening risks, including coronary obstruction, annular rupture, and also for the follow-up with no risk of leakage and low risk of conduction disturbances. This is what we want from every device. So when we presented our initial experience with this balloon expandable valve, we found a lower rate of major vascular complications. This was a retrospective match study. Of course, it's not comparable. We will need the results of the randomized landmark trial. But this gave us a hint that the Python introducer, which is a 14 French introducer sheath, could proportion a good access with lower risk of complications than other technologies that have larger frame introducers. And now we have some novelties regarding introducers for the lower valve devices, balloon expandable. We have a 12 French introducer sheath that is under research for CE mark approval, and this will really change the game, and we might even consider lower profile accesses, subclavian, brachial artery. So this is opening new fields that are really impressive for the future. Regarding the positioning and the implant stability, it's important to have a delivery system that is flexible. Remember the first delivery systems that we had with TAVI that were very large, not flexible. We were scratching all along the aortic arc. So these kind of properties are particularly important. Of course, the more flexibility we have, the more difficult it is to cross the valve. So the engineering process behind that has to maintain this kind of flexibility without losing the energy to cross the valve. And the navigator inception can provide this interesting aspect. And then the positioning has different aspects. First, again, the flexibility of the system is a good thing, but we can have more difficult positioning in the aortic annulus. And then there is the foreshortening issue. The longest the valve is, and the more number of cells there are, the more foreshortening we are going to experience, which represents less predictability when we are implanting a device. So if we see the self-expandable device, we see that the foreshortening when it's crimped and when it's implanted is 44%. When we have a balloon expandable first generation device, we can see that foreshortening can be up to 25–26%. And with MyVal octa-core, we have around 19–20%, which is the smallest foreshortening with the devices that we have in the market. Why is that? Because of the number of rows and the only 2 rows of and the large cells. This is the reason that Glenn explained the smaller foreshortening. Have a look at this case. Often when we are trying to implant a balloon expandable device, and now we are moving to cusp overlap implantation as well, our fear is to have a greater foreshortening that can be led due to the tension of the delivery system, but also the structure of the device. So having this precise foreshortening can help us to implant in cusp overlap view and to have a low conduction disturbance rate. Regarding other major life-threatening complications, when we published this paper in catheterization and cardiovascular interventions with the MyValve first generation device, we saw that all the major complications, including valve embolization, coronary artery occlusion, annular rupture, etc., were happen in no patient. This is very important. With balloon expandable devices, often what we see is that we have better results in terms of leak compared to self-expandable devices, and similar results in mortality. But the reason for that is that the mortality that we see in balloon expandable patients is very small due to the annular rupture, coronary obstruction, so it's never significant in the trials, but it's something that is concerning us. So when we do the CT analysis, we always check for these issues, and if we anticipate a high risk of annular rupture or something like that, we move to self-expandable devices. Well, here we have a virtually zero rate of these major complications, and I think this might be related to the fact that there are intermediate sizes with the MyValve octacore technologies. Why is that? When we are implanting a balloon expandable device, our target, if there is a lot of calcium in the valve, is to oversize between 0 and 5%. If there is not so much calcium, we can go for 5 to 10%, which is different in self-expandable devices where we go to 20%. So with the intermediate sizes, we can have a lower degree of oversizing with adequate gradients, and this can prevent these major complications that can be life-threatening. This is a 24.5 millimeters octacore device. And also you can see another interesting aspect, and is that, of course, it's a balloon expandable valve, of course it's intraannular, but actually the leaflets are sutured a little bit high within the stent frame, and this means that it's a few millimeters supraannular. We will not say that this is a supraannular device, but the intermediate size together with this positioning of the leaflets can provide better hemodynamics compared to other devices. How often do we need these intermediate sizes? This is the low-risk registry that we published. It was used in 39% of the patients. And if we check the recent publication by the group of Professor Ruiz, again, this proportion of use of intermediate sizes is similar in about 40% of the patients. Does it play a role in the hemodynamics? I think it might does. It might play a role in conduction disturbances, but it also can play a role in the risk of these major complications that are annular rupture or coronary obstruction. And regarding the follow-up, for us it's important to achieve the best results in terms of leakage. So when we are in large anatomies, the availability of these extra large sizes with this skirt can be particularly useful to avoid leakage, which is more common when we need the SAPIEN 329, but we are a little bit undersized because the annulus is too big. So we are covering this range of patients, and in the matchball study, where we compared these balloon expandable technologies, we could see that the results in severe leak was virtually the same with both devices, only one case in the SAPIEN 3 arm, 0 cases of severe or moderate regurgitation in the MyValve after matching for anatomical variables of the annulus. We are using these extra large sizes also for pure aortic regurgitation. In pure aortic regurgitation, normally we have greater residual aortic regurgitation in the follow-up. So we can see that at 1 year we have 2.1% of patients with residual severe regurgitation, but still we are oversizing a lot. We are using this valve in non-calcified aortic valves, and the results are quite good compared to the recent publication meta-analysis suggesting a rate of moderate or severe regurgitation around 9% with other alternative devices. And finally, regarding what we look for in terms of conduction disturbances, the high implant is very important, so the foreshortening issue that I mentioned before is very important. This device is aimed to be implanted around 3 millimeters depth in the LVOT. And when we compared the pacemaker rate across more than 1,000 patients, we found that the MyValve first generation had a pacemaker rate of 7.5%, which compared favorably to Evolut, 18.5%, Portico, 29.5%, and Allegra, 22%, and was not significantly different from SAPIEN 3, 13.4%, and for Evolut, from Accurate, 9.1%. If we check the PRS segment in the core lab analysis of the electrocardiography, we see that there is an increase in the duration of the PR segment, but at discharge, this is corrected. There are no significant differences across devices, but the QRS duration at discharge is significantly prolonged in most devices, but the lowest values of the QRS duration are obtained with Accurate and MyValve first generation. So in my conclusion, this new device can offer a low profile, good navigability, and crossability. The positioning is more stable and with less foreshortening than with other devices. We have a low rate of the life-threatening risks, virtually no leakage in regular anatomies, and a low rate of conduction disturbances. Thank you very much.
Thank you for this excellent presentation and being on time, so it leaves us a bit of time for questions. Maybe I can ask Francesco to comment on what you think about these design iterations.
Congratulations, first of all. There is the major problem of balloon expandable valve probably now is considered especially in small annulus, the gradient and the valve area. There's some data that there's something different between a balloon expandable valve and the hemodynamics of optical is better than SAPIEN 3. Could you tell us something about that?
So these data are retrospective. What we compare was matching the baseline left ventricular function, the baseline gradients, the annular size. So this matching has some quality, but it's not prospective. We have to wait for the landmark trial. But still, it makes sense that having intermediate sizes can give you some extra size of the effective annular area and can be associated to lower gradients, which is very important, especially in the low sizes of valves, because it can be associated to better durability.
You didn't talk about coronary access at all. Do you want to mention something about that?
So coronary access with balloon expandable valves that have a short frame usually is not an issue. It can be an issue if we need in the future a TAVI TAV. So in this regard, it is important to obtain adequate commissural alignment or coronary alignment. This is not to protect from occlusion of the coronary, but in the future, if we need to implant a second valve, we need this. The Octacore system has implemented the Octaline strategy, which is a strategy to increase the rate of commissural alignment with balloon expandable devices. If we don't do anything with a balloon expandable device, the rate of malalignment is more than 50%. So this strategy probably is achieving around 70% of adequate commissural alignment, and this will be important when this valve degenerates in 10 years, 15 years, and we need a second device.
I'm sure we'll hear more about that a bit later. Anybody got any questions from the floor? Right, so we'll move to the next talk. Thank you very much. Let's call Ingo Eitel, please, to discuss procedural and clinical relevance of the wider size matrix.
Thank you, dear Chairman, dear ladies and gentlemen. It's a pleasure to be part of this session. So, 20 years of TAVI, so what a success. So we have a rapid technology evolution. That's why we are here in this session. So we have procedural refinements and simplification and luckily a dramatic reduction in complications and improved outcomes. And we now have really the data, the randomized multi-center data. We have transformed the use of TAVI from high-risk patients to intermediate and nowadays low-risk patients. But despite this success, we still face severe challenges in TAVI treatment, and this has to do with TAVI durability. So we already talked a little bit about coronary access, and we heard from the first speaker about pacemaker implantation, and also peri-device leak is a very important issue, also with prognostic relevance for the patients. And one of the open issues is also the patient-prosthesis mismatch. So we know this mainly for the heart surgery valves. So in almost 1/3 of patients, we have a patient-prosthesis mismatch, but this is also true for TAVR patients. So we have it in approximately 10% of patients. We have a prosthesis-patient mismatch in TAVR. And therefore, we really need the optimal device size for our patients. And this is dependent on the anatomic factors, on the annulus size, on calcification. We already talked about coronary access, horizontal aorta, if the patient has heart failure or he has kidney disease. And as you can see on this slide, we have plenty of choices. We have plenty of sizes. We have balloon expandable, we have self-expandable, and now we have the latest innovation, we have now 9 sizes and possibilities to even treat larger annulus sizes up to 32 millimeter, as we already saw in the first talk. And now we are going to the prosthesis to patient concept. We can preserve the prosthetic valve geometry and respect the patient's anatomy. And you can see here the 9 sizes of the MyVal octa-core. We have 4 intermediate sizes, and as compared, for example, to the competitor balloon expandable device, the Edwards Sapien, with only 4 size possibilities for our patients. And as we already saw, yes, this has clinical impact, because in approximately half of our patients, we use these intermediate sizes, and this has also impact for the final results and also probably for long-term prognosis of our TAVI patients. And therefore, one of the take-home messages is clearly of this talk that we have to tailor our choice and size of the TAVI device treatment to our patients. So why does size matter? So we already discussed some of the important points, but for me, PVL, paravalvular regurg, is one of the important factors. Also pacemaker implantation, but we also want to reduce the life-threatening complications like valve embolization or mainly also annular rupture. And that PVL matters, we know from many registry data and also randomized trials, and we now have the innovation from the first generation of the MyVal to the MyVal octa-core. And the octa-core has an anti-PVL new skirt and internal lining and complete cover. And we have the improved device frame design and also cell shape, and this can probably avoid PVL even better as with the first generation. And we already have convincing data. We have a very low rate of PVL with the MyVal octa-core implantation, and this is also true for complex anatomies, for example, also for bicuspid anatomies with very convincing data. And here are some examples of our lab, our structural heart valve center. So you can see 3 different patients. You can see the results, and you can see no regurg at all, or only mild or trace aortic regurg. And we now also have somehow randomized data. These are data presented at the TCT. So it's a sub-study of the COMPARE trial, and 330 patients were compared, and in this trial we saw that the MyVal generation 1 and also the octa-core is non-inferior to the Sapien Edwards valve, and the data are not published yet but were presented at the TCT. And what is also an important unmet clinical need are the XL sizes. So this is in the clinical real world in up to 10% of our TAVR patients. So, and the currently available device prosthesis can only cover annually up to 750 square millimeter. And if we do excessive overdilatation or post-dilation in these patients, we have a severe risk for suboptimal leaflet coaptation leading to significant regurg, PVL, and also to early valve deterioration. So we can also damage the conduction system, probably also resulting in AV block and pacemaker implantation. And as we already have seen, we have now the possibility to have a true XL TAVI prosthesis up to 32 millimeters to really treat XL diameters, XL annually with a XL valve. And what is really elegant, you can also use the larger valve size with a 14 French Python sheath. And you also have the high convenience that you can do full retrievability of an undeployment system if the anatomy will not match with a valve. So, and at the end, one of the examples of our lab, it's a very large annulus. You can see the diameters was measured in this Remensure system over 840 square millimeter, and the annulus size was 32 to 33. We had severe calcification, and my fellow came to me and said, sorry, this patient is not treatable with a TAVR, so is he probably a candidate for surgery? And I said, no. So we have now the option also to treat these large annuli. And you can see here the pre-dilatation and the severe calcification in the patient. Then the positioning of the 32 millimeter MyVal octacore prosthesis. Here the implantation of the valve, and you can see the great result without any severe regurg in this large anatomy size. So in conclusion, in my opinion, optimal TAVR device selection and sizing is absolutely essential for optimal TAVR results and also for the reduction of complications. The broader size matrix of the MyVal octacore ensures optimal sizing in all of our patients. We have the intermediate sizes, and the intermediate sizes are used and in half of patients in clinical routine. And if we have the optimal size for the individual patient, we can probably reduce PVL, we can reduce pacemaker implantations and all of the major complication like annulus rupture, and probably we have a better durability of our valves. And the XL diameters and sizes is really an unmet clinical need. And with the XL octacore, we have now the ability to expand the TAVR indication also for patients with large annuli, and probably also for bicuspid anatomies and people and patients with non-calcified aortic regurg, because these patients usually have wide annuli. Thank you very much.
Christian, can you tell us how many patients in your series used intermediate sizes?
So we randomized 1,031 patients in the COMPARE TAVI trial, and when we look at the MyVal octacore, it's 1 out of 3 patients where we use the intermediate sizing. And of course, there are many indications that it's good to have this option, because previously we either undersized or heavily oversized. But I think we still need to see the results from the landmark and the COMPARE TAVI. We'll have these results at EuroPCR and next London Valve. Also, it's great with these XL sizes, and also in our institution we have now a new toolbox, a new equipment in our toolbox. So we also use XL sizes in like approximately 1 to 2% of our cases. I think it's important also to mention that it's not only for aortic implantation. It's also a good device to have if you want to do valve in mitral position, valve in MAC, and also, as you mentioned, if you have aortic regurgitation where we normally oversize like 20-25%, then you will have cases where you cannot treat them with previously available devices.
I believe there's also consideration for even larger valve in the future.
I think there's a 34 on the way.
35 even, I think.
Yeah. That's going to be niche.
All right, thank you very much. Any comments, Andreas?
No further. Just one question, just practical. when we the standard balloon expandable valve that we use, the Edwards, we often do +2 milliliters, +5 milliliters if it needs to be big, -2. All that goes away, right?
Yeah. So usually you don't need excesses over dilatation or to put more in your balloon to have a proper implant. So this is moving away.
Maybe one short question, because we see that the valve is already on the balloon. So is the predilatation, in your experience, necessary, or it just goes straight forward?
Yeah, so sometimes you have problems to cross the valve if it's severely calcified, if you don't predilatate. So this was in the case I'm showing in the large annulus size. This was the main reason that we were a little bit concerned that we cannot put the valve over the very calcified aortic valve stenosis. So we decided to predilatate, but probably. Probably predilatation can be a little bit more avoided with the MyValve, and this probably also has impact on strokes. So so it's an important issue.
On the other hand, the valve design gives us a huge radial force, so it's a good option for heavily calcified patients.
I think there's one important point here that you can take it out again. So you can take it out as long as you remember to put in the the loader. So you if you have problems crossing, take it out and then predilate. So
good. So I think we need to move to the next speaker, which is Henrik Nissen. Thank you very much. Who will talk to us about commissural alignment, and I'm very interested to hear about this one for balloon expandable valve, which traditionally has not considered commissural alignment.
Well, when I was asked to do this presentation, I honestly didn't know that there were so many presentations hovering around this topic of coronary alignment. So you will have some déjà vu on some of these things, but hopefully I'll give you a new look on some of it. And in essence, in the last part of it, you will hear the specifics on the alignment of the octocore, which is new to the most of you, I guess. Okay. So this is my conflicts. So why do we care about this lifetime management? Well, that's because we're going to put these valves in younger and younger patients. You know, the European guidelines goes from 75 years of age, and the American guidelines have this gray zone area of 65 to 80. And this gray zone area is actually not that great, because when you look at the numbers, they actually implant close to 90% of patients range with a TAVI. And of course also in the elderly patients, but the more interesting point is you're close to 50% of TAVI implants in the below 65 years in the States. So it's a really huge number of potential patients where you need to have a thought about the lifetime management. And there's a lot of stuff you can talk about in lifetime management. I only focus here on the coronary reaccess stuff, not the other things not important, but for the sake of time, this is what I'm focusing on. And just a few topics we need just to be sure of. We are talking about the coronaries can be centered in the cusp or the sinus, or they can be eccentric. So you have a commissural line which is centered between the coronaries in one case, and you have the off-centered for the commissural line in the eccentric cases. And you have a definition of different grades from 0 to 10 and up to above 30, given it from no deviation to severe deviation. But luckily, in most cases, there's not much of a difference. So more than 90% of patients, it really doesn't matter. The coronaries are quite centrally placed. So, nevertheless, you have to talk about commissural alignment and coronary alignment. So, commissural alignment is when you put your new valve completely aligned with the old commissures. Whereas the coronary alignment, there you focus more on aligning them to the coronary, so you have optimal access to those in a later procedure. And there's a lot of potential benefits theoretically on commissural alignment, and I won't go into details of that, but there could be improved hemodynamic performance, and definitely when you do finite analysis, you will have reduced leaflet stress, and you can also envision improved expansion of the stent struts if you align them correctly to the old cusp. But the definite practical benefits is unrestricted access to the coronary osteotomy for future interventions, And leaflet modification techniques will in many anatomies ideally only be performed if we can secure commissural alignment or coronary alignment. So for the self-expandable valves, we do have this option already. Most in the accurate, this is just a continuous study from Copenhagen where they try to do optimal alignment in 20 consecutive patients of these 3 valve types. And as we already know, the accurate neo is the best in obtaining that, but the other valves do pretty well. But they also have this option also this problem of the stent post area is quite large, so you have to be more precise in putting this valve in order not to cover the coronary osseous. Whereas in the other self-expanding valves, like the SAPIEN and Octacore, it's a quite small area. But does it matter? Well, it does, because here in the Align Access study, they try to intubate the coronaries immediately after putting in some sort of a valve, and you can see the balloon expandable valve, it was pretty good. There were no cases where they couldn't access it. But even if they tried to align a supraannular valve, the results were not that good. So for valve and valve, the new issue of neoskirt comes into play. And you see when I put my finger in here, the old valve actually comes a pretty high covered stent. And that has to be taken into account. And when you put in a low frame valve in a high frame, you get less of a covered stent, but a high frame in a high frame will really give a high covered stent situation. And the different high frame valves give a little bit different, but approximately around 30 millimeters of covered stent, whereas the balloon expandable is obviously shorter. So when will the neoskirt be unproblematic? That will be when the risk plane of the coronaries are above in the SAPIEN cases, or if there are a good distance from the sinus to the valve, you can put in your catheter without any problems. So these cases, afterwards, you will be able to do standard valve and still allow coronary access. But there are cases where the neoskirt gives a high risk. If these distances are short or they are definitely above the risk plane, then you can have problem in intubating the coronaries. And that will, by the way, be completely the same issue if you're talking about valve and valve. But so in these cases, you will have compromised coronary access. But couldn't you just do cusp modification techs with the basilica or with some of the newer techniques will be coming? Well, you could do that, but if you do a cusp modification, when you have a completely nicely aligned coronary and the valve, you do a cusp modification, you get free access to the coronaries. If you don't align the valve, you get cusp access at a place where you can't intubate the coronaries. So while you have this ideal on the left side, kind of the pointer here, okay, maybe you can see it, I can't point, but there's, oh, here it comes. This part, of course, what we want to do the slice, in this case in a biological surgical valve, just in front of a coronary, and then put the new valve and valve completely well aligned, so there's no problem in accessing. But in essence, you often end up with a little bit offline, in this case completely offline, where you cover the access. So regardless if you've done your nice cusp modification, you will not be able to access the coronaries. So coming to the Octacore, the unique thing about the Octacore compared to the SAPIEN is that we are allowed to do commissural or coronary alignment. I'll just go through a little bit of the theory behind that. So what we do is we have this specific crimper with a dial on it. It could be, as let's say, clock, or it could be degrees. But then you put your stent post in a well-defined position that you define on the basis of your CT scan. In this case, it could be like 1203 on this clock. And this will allow you to put it in an optimal position once the valve gets to the annular level of the patient. And the reason why that is because when you put the valve in like this, superior in the crimper with one of the posts, when that gets into the patient, it gets anterior. And as it moves along the aortic arch and down to their well, it gets completely turned around, so it's 100 degrees opposite. And these things you can actually plan, because if you have your standard three-cusp view here, you can align your implant so that when you put it in the crimper, you put it in this case at 12 o'clock, because the RCA is just straight at 12 o'clock in the center of the right coronary cusp. And then when you put it into the patient, it ends up completely opposite, and we keep complete coronary alignment. And if the RCA on the right cusp is a little tilted, Then you just do another placement of that marker and place it, in this case, 10 to 12 or minus 60 degrees. And once again, when you put in your valve and do it 180 degrees opposite, it comes completely in place. So when there is a difference between the coronary and the cusp placement, as I showed in the first place, then you have to do some other things. So in this case, just to show, this is a standard patient, everything is normal, but when the coronaries are aligned off-center, you have to do other stuff, because if you just put it in as you use, then you will get this situation where a very narrow distance between the new stent post and the right coronary artery, which will give you some trouble in accessing those later on. So in those cases, you use the coronary alignment. You find the equidistant point between the two coronaries, and then you just subtract 60 degrees from that, and that will be your new position for your crimping angle. And when you do that, turn it 180 degrees around, then you have optimal access, and now you have a much wider angle to attack the coronary. So we just finalized 1,031 patients in the SAPIEN octa-core COMPARE trial, and while we await the sub-study of those patients where we will be seeing about these coronary alignments, how good it really is, we have a single small publication with 30 patients, where at least in like 80% of the patients we had an access possible afterwards, only 17% where there was complete coronary occlusion or occluded access to the coronary. So, coronary alignment, cusp alignment will be highly relevant for lifetime management in the younger patients, both if we start with TAVR, but also if we start with SAVR. And for now, the octa-core system is the only one which allows this for balloon expandable valves, which then again allows us to tailor optimally the valve and the sizes for the patient. So, thank you very much.
Thank you. Beautiful slides. Martin, you want to comment on this presentation?
Yeah, maybe just short comment, because when we talk about life management of this patient, the coronary access is a mandatory thing. So we have here with this design of the valve two important aspects. First one is that is a low frame valve. It will resolve many cases, problem to access to the coronaries in many cases. The other one is the technique you just described called octaline, and it preserves the right positioning of the valve.
One quick comment and we must move on.
So I think I agree with you, Henrik, that we should focus on coronary alignment instead of cusp alignment. But should we go further and then aim at left main alignment, because often the right has a very high takeoff, and in reality it is the left main. So shouldn't we actually focus on the left main?
Well, in practice, that is what we almost always are doing. If we have, I mean, these are rare cases. We have to take that into account, as I showed initially. There are most cases it doesn't matter if you do coronary or commissural alignment, but in those rare cases where it does, you have to look at the size of the right coronary. If you can ignore that, or if it's pretty large, you don't ignore it, then you have to be somewhere in between.
Are you doing these calculations yourself, or is there now a software availability in 3Mensio to help you with this, or other software?
This might look complicated, but it is so simple. It is really, you just do it. I mean, basically, once you've done some of them, you can do it by eyeballing. Actually, you get a feel for where you have to do it. It's not complicated at all.
I personally think that commissural alignment is very important, and but we should achieve it in 100% and not only in 80%. What's the reason for this?
Well, I don't know, but
I think, sorry, yeah. All patients have a CT scan. We have the exact anatomy of the aorta and the groin arteries, so it must be possible to calculate with a computer program. Having in mind where the ostia, they're not in the middle. You have shown this very nice sometimes, so that you can calculate the exact position, and then you put the angle, and then you.
That is in theory completely correct, but there must be happening occasionally something about when you put the valve all the way down, then you get some torque. It's same as when you do the evolute, you put the marker out there, but when you come to the valve, something has happened. It has made some turns, and it will never be 100%. But it's compared to have no cusp alignment with the SAPIEN valve, you definitely get a much higher. But it will be interesting because In this compare study, we try to, in all cases, to do the coronary alignment, and we actually have these 500 plus patients, so we will get much better data to see where it aligns.
Wait to see that.
The other question is, what do you think if you have markers to turn the system?
Sorry, come again?
In case you have markers on the valve to turn the whole system.
Yeah,
I personally think it's not a very good idea because it's so flexible, so it's not stiff enough to get the drill to change the position in.
I have the same feel because it also is a little more flexible, and so you might not. But I've never tried it because you don't have any markers on the very large valve. You can actually see the post, but I haven't tried working with that, to be honest.
Thank you.
Thank you for that interesting discussion. Let's move to the recorded case now. Which will be guided through that by Andreas Holzhammer. Thank you very much.
Thank you. So I want to present that case. It was a 79-year-old male patient, quite fit for his age. He was presented by a referring hospital where he came in decompensated with a new diagnosed high-grade aortic stenosis. He had a slightly impaired LV function, 51% was measured, and had also a new diagnosis of a coronary artery disease with a diagonal with 50%, was treated conservatively, obviously. In his patient's history, it's interesting that he got a pacemaker like half a year ago. He did not report dyspnea at this stage, and they said it was most likely due to an AV block, but maybe he syncopated, basically. However, the ventricular pacing rate was only 0.2%. And looking at this patient, obviously not frail at all. He's a low-risk case with SDS Euroscore of about 1.4. So the patient was sent to us. We do a CT scan, of course, due to the patient's age, to screen for TAVI. You can see the anatomy is quite standard, I would say. We have some minor calcification at the level of the annulus, but nothing to be worried about. Coronaries look good. There is some calcium in the ascending aorta that might be not too nice to do open surgery. The vascular access is excellent. Basically, there's a bit kinking on the right axis, left axis also. However, still a very good vessel with diameters of almost 1 centimeter. In our heart team, of course, by guidelines, 79 years old, good femoral access, suitable anatomy, of course, a TAVI candidate. But I think this is only one aspect of the heart team decision making. And the other is to look for what are we aiming for. And in this particular patient, although he's 79, he has probably a life expectancy at this age without any severe diseases. He had some diabetes, however, that is controlled by sports and nutrition. So this guy probably will get 90. Once he reaches the age of 80, these patients live long when they have a healthy lifestyle. So one consideration in low-risk patients, I think almost regardless of the age, is that we should have redo options. The other thing, of course, he has some coronary artery disease, not very severe, but it might happen. The other thing is, of course, to preserve the coronary access. And then it would be a bit easy to say, well, he has a pacemaker in place, let's just implant a valve and see what happens. But still he has this LV function of 51, which will not limit him, of course, but if we implant a valve and have further damage on the conduction system, 100% pacing rate, that for sure will have impact on his LV function on the long term. So the progression of these rhythm disturbances should also be avoided. I skipped quite quickly through the CT, but and I guess you couldn't see the numbers anyway because of the text size, but the area was 557 square millimeters. What we do then is to put that into this quite recommendable small smartphone app that you can find in both of the app stores, which is provided by Merrill, and there you just put the area in on top, right here, and then it gives you the 3 most suitable sizes, which are displayed here. And there you can see the procedural oversizing. And my strategy is to look in a standard case for an oversizing of 5 to 10%. Literature is not quite good. We don't know this by very good data. But that seems to be a fair compromise between rhythm disturbances on the one side, annular rupture, and on the other side, good sealing for PVL. Of course, you should look at the short diameter here, maybe at patterns of calcification and so on. But in this standard case, I would aim for 5 to 10% maybe. And if you look at the valve size matrix, then you see that 26 definitely isn't an option. It is too small, also in regards of hemodynamic function and redo, in my opinion. 27 looks very good with 6.6, and 29 with 18% of oversizing is definitely at a higher risk of a pacemaker. So here we decided to go for the intermediate size 27.5, which is, I think, quite obvious. In the next step, in low-risk patients, we simulate the redo option and coronary access option. I think it makes sense to do this three-dimensionally by segmenting the aorta, put a stent in here in a 90% aortic position to have like a worst case scenario, and look if we still have a good area to access the coronaries. And the cylinder you see here is basically the full opened leaflets in the height of a 27.5 octa-core. So I think the best way we can predict what happens. And obviously in this case, the risk plane is below the coronaries, and we still have a large area also to access them also when we do a valve-in-valve in future. So let's jump into the case. It's a bit operator dependent and case dependent. Here we went for bifemoral access. We do image guided puncture. In this case here using SmartMask, which is a Philips name for basically a subtraction angiogram, where you have a live puncture and you see the needle here in the right groin. But of course, this is depending on your local practice and expertise, what way should be preferred. We normally use a stiff wire for each sheath insertion, so don't go over the safari, but put the sheath in at the very beginning. I think it makes sense. We never saw a case where we had a big sheath in and couldn't cross the valve at all to proceed with the procedure. So that is our strategy. I think I skipped something. No. Okay. In this large vessel diameters, MANTA is a good option in my opinion. So we used here the MANTA system. In the first step, if you don't know it, you need to measure the puncture depth or the depth of the vessel by this blood indicator. I always do a small cut for each sheath to just get the transition through the skin easier. And now the Python sheath that comes in a box with the whole package of the valve is inserted. We learned it's a 14 French sheath in the current iteration. It's a, I think, fair compromise between flexibility and stability to get push on the system, but still I use for all expandable wires, for all expandable sheaths a relatively stiff wire. Stabilizes a bit with the left hand while advancing, and you can see here that, as expected in this anatomy, there was absolutely no issue. I think it's important to mention that this sheath is really 14 French till the end. Most of the self-expandable sheaths of the two other companies who offer it are at the end tapering, getting larger. And the point of the vessel entry is in the tapered area. So you basically have a larger hole than 14 French, but this has a good effect on sealing. This sheath has a different mechanism of sealing, and therefore it's really important to advance it till the end to make sure that you have good contact of the sealing structure to the vessel. But besides, it's a easy to use sheath, of course. While we do so, there is some footage of the device preparation here, which is done in parallel, of course. It's basically a straightforward process, the crimping. The valve is directly crimped in between two conical structures inside the balloon. They're called stoppers by the company. And the valve is crimped in there with the device. Easy to learn, which is, I think, good for the staff shortage that we face in our days. So basically it's a system that also the physicians can crimp themselves at night when you face emergencies or however. Quite a good system. In the end, you have a loader that is sheltering the valve while inserting it into the hemostatic valve of the sheath. Okay, we start in a three-cusp view, confirm this by one angiogram, and then the valve is crossed. Our standard technique is AL1 and straight Terumo wire. But again, this is of course up to your preference. Valve crossing wasn't very complicated here or time consuming. And see the jet here deflecting the Terumo already in this true stenosis. And then in the next step, a safari wire is advanced. The system is inserted by holding this small insertion head and then advanced. You see that it's quite flexible and you need to somehow stabilize it while pushing. There, the main resistance is the point where the valve is entering the vessel and the Python sheath is expanding the most. And then it's basically pushed forward. You see, I think this is quite interesting to watch here. You see there's like a dorsal bend of the aorta. You see the valve just traveling through. We flex it before entering the aortic arch to avoid the most contact to the aortic wall possible. But to be honest, we didn't even visualize this here. And then you sometimes have this finding that you're in the outer curve and somewhere have some resistance to cross the valve. We did not predilate. I think it's helpful to play with a flex here, as I did, and then just maintain gentle pressure, and then it pops through. You're too deep at this stage, of course, obviously, a bit deeper than intended, to be honest. But your last movement is backwards. And that is kind of important in this device, because the flexibility of the catheter also means that you need to stabilize it during the implantation. That's the downside of it. And this is way easier when you're in a backward movement, because the tendency of the system, it opens symmetrically, but the tendency is that it wants to dive into the ventricle once you start deploying. And of course, the movement you need to do to encounter that is to pull on the catheter and push a bit on the guide wire. And that is, of course, way faster and easier if you're already in a backward movement. So therefore, that is my recommended implantation technique. Now, the deployment is done, of course, under rapid overpacing, which is performed here. You see the positioning marker at the level of the annulus. We do one final contrast injection. You see it diving down a bit, but not really that we needed to do a major correction. And the inflation is performed. We hold it for 5 seconds to make sure that the stent really has the time to expand, deflate, and the patient was immediately recovering from that episode of rapid overpacing. Removal of the device. If you still have some flex in most cases I don't have any flex after crossing the valve, you shouldn't forget to unflex, of course, and basically pull it out of the sheath. The result was good. No visible regurg in the angiogram. You can see here that we remove the sheath and apply the Manta system. I don't think it plays a role that we used octa-core here, whether this is beneficial or not for Manta or ProGlide. I think this is just by your local expertise, of course. Mm-hmm. However, I think we have the time to look at this still. Manta, for those who don't know, is an intravascular anchor, which is resorbable, and a collagen plug, which is on the outside of the vessel, so like a very large angioseal, basically. That is applied here. We had immediate hemostasis. For that case, we put a temporary transfemoral pacemaker in that we just retracted afterwards. Patient had a pacemaker, as I mentioned anyway. And then control was eventless. So here again, the result also in echo, to see no evidence of regurg and a mean gradient of 9. So hemodynamically, for sure, a good result of the patient. And to conclude, it was a very straightforward procedure. Skin-to-skin time was 19 minutes. We did see good hemodynamical outcome. Postoperative course was eventless for the patient. He had in the follow-up also a good clinical outcome. And in ECG and also the pacer stimulation rate, there was no change at all of the conduction system. The implantation height measured here was like 80-20, which is I think, okay, we could aim for a bit higher implantation, to be honest, but this, of course, is a trade-off of redo options. The higher you implant, I think we tended to implant very high, many valves, ending up in possibly restricting options for redo process and coronary access. So I think this is a fair compromise here, and obviously, as we didn't see any changes in the conduction system, turned out to be good for the patient here. Okay, thank you.
Excellent.
It's very noticeable what a small footprint this valve has when you look at it.
Especially in the large sizes, so 32, the first couple of cases, it really feels wrong because it expands so much laterally, but almost not to the aorta. Yeah.
Michael, do you have comments on this case?
I think it was a straightforward case, and I personally think the high is okay, and of course there's a tolerance. You try, and if you do the first case, it feels extreme high, so it's a difference to Edwards.
But surely to leave the least possible amount of material has to be the best. To have the lowest frame height, allowing you to get as high as possible to reduce your pacemaker rate.
Yeah, I think you might have the point at a certain point that you compromise on the leaflet stress. When you have a short commissure height, leaflet stress might be higher and in a relatively large ratio. So I think this is the downside of having very short frames, but definitely for coronary access and redo, short frame height is worth more than everything else.
Francesco?
Is it clear how is minimum the foreshortening of this valve? Absolutely, it plays in a perfect position. It doesn't change anything. So it's a very minimal. And this is true even with the large annulus, because we did a survey with Dr. Alzheimer about the how many you find very large annulus. We are around I think 4% of annulus that is not treatable with the commercial and treatable with 32. Mm-hmm. So it's,
it depends, of course, if you say what is common use of oversizing in conventional devices. I think there's case reports where people really put like 10 millimeters more volume into a 29 Sapien. But of course, I think the good data, the XL registries, at least that we have, there's no randomized data at all in this field, of course. But this is that you can do this up to 740, 50 was, I think, by Ignacio mentioned, which is reasonable. And everything above is definitely needing a bigger valve in the end. And of course, if you have it available, why should you compromise? The valve is intended to function best in the nominal diameter, so no question about that.
Not increase with 5 or 6 cc anymore.
Christian, I see you want to say something.
No, it was just I saw you struggling a little with getting the valve inside the sheet. So normally there's this 18 French dilator.
Yeah, we skipped this honestly in the presentation because at this time the preparation of the valve was filmed. No, you predilate at least from 27 on. You predilate with an 18 French delivery system, 80 French dilator, which is in the package of the sheath for all size. But you once put this dilator in and out, which is massively reducing the amount of force you need. I also do this now for Sapiens 29. Okay. There's dedicated dilators by Gore, and that is definitely feeling better afterwards to push the valve through it.
Any final comment from you, Andreas?
Sorry?
Any final comment from you?
No, I think the one thing we haven't seen is the octaline in your case, right?
Honestly, in that particular patient, we didn't do that. But I think you cannot lose by trying. We do it also in some cases. The impact for that particular patient will not be high, I think, because we had very clear access to the coronaries. Of course, sinus wash out, these points. Yeah. No reason not to try.
You're saying you didn't do the alignment because you're below the coronaries in any case?
Yes. Yes. I think the redo and all was...
Yeah.
So, thank you very much for that good case.
Thank you.
I think what we've seen today is that this new octa-core valve has a very low footprint, which gives you options, both in terms of intermediate sizing and the height above the annulus, to optimize coronary access and to reduce pacemaker rates, and is the only valve which is balloon expandable, which has the potential for commissural alignment. So I think we've learned quite a few interesting points, and it does appear that this valve has some features which look very attractive and offer some innovation which potentially will be beneficial, but that needs to still be demonstrated. And we await, Christian, some of your data with keen interest.
Next year, randomized data.
And I want to thank Meryl for this session and all the speakers for their excellent presentation and being on time, and to the discussants for their succinct comments, and enjoy the rest of the course. Thank you very much.